May I invite our first speaker, Professor Dr. Wong Sawe, Consultant, Pediatric Neurologist of Hospital Chancellor Tuanku Mukhriz, UKM, to start the lecture sessions. He will talk on topic Epilepsy Basics. Doctor, the floor is yours.
Can I share my slide?
Yeah, sure.
Yeah. You can hear me well?
Yeah.
Okay. Thank you, Encik Faris. And good morning, selamat pagi participants from Malaysia and Indonesia. Sawadee-kap, Sabai Mai from Thailand, Maganda Umaga from Philippines, and from Vietnam, if I get it right, Chao Bosang. Now, I'm going to talk about epilepsy, the basics this morning, and my task is to let you know what is epilepsy, what are the types of seizures, and what causes epilepsy. Epilepsy is one of the most common neurological problems in the Western world. It is the fourth commonest neurological problem following stroke, migraine, and Alzheimer's disease. Its prevalence in a recent study in Malaysia is found to be 7.8 per 1,000 population, similar to that of Thailand. And the prevalence of active epilepsy is 4.2 per 1,000 population. So using this figure and extrapolating it to other countries, and using the demography from your country population statistics, I found that in Malaysia, the rough estimate of patients with epilepsy under 14 years is around 32,000. In Indonesia, it is about 267,000. In Thailand, 49,000. And in Vietnam, 94,000. The incidence is highest in the young age, extreme of age, in the very young, less than 5-year-old, and in people above 65-year-old. There are about 65 million people affected by epilepsy worldwide, with 80% of them living in developing countries. And there are about 10 million people under 15-year-old with epilepsy. Now we go look at the history of epilepsy. The first description of seizure was recorded 2,000 years before Christ in Mesopotamia, when the author described the patient as having his neck turns to the left, his hands and feet are tense, and his eyes wide open, and from his mouth froth is flowing without his having any consciousness, describing a seizure attack. However, the exorciser diagnosed the condition as Antasubu, translated as the hand of sin, brought about by the god of the moon. So since antiquity, this condition has been linked to the mystic and to sin and to having mystical origin. Hercules is thought to have epilepsy as well. And in ancient Greece, it was thought that people who offended the Selene, the goddess of moon, were afflicted with epilepsy. However, the father of medicine, Hippocrates, first challenged this view when he wrote that the disease was thought to be of sacred character because people like magicians, purifiers, charlatans, and quacks who claim great piety and superior knowledge has no idea what it is, and they try to conceal their superstition behind their ignorance of the disease with the sacred. And he thought that this disease is caused by affliction of the brain. So it is a disease of the brain, which was first mooted by Hippocrates long before Christ. And Ibn Sina, a famous physician and a philosopher, was the first person to describe epilepsy as being possessed by an outside force in Latin, when he wrote in his Canon of Medicine. And in modern medicine, John Hewling Jackson described epilepsy, which we still use now, as the name for an occasional, sudden, excessive, and rapid and local discharges of the gray matter The gray matter is the outer layer of our brain, as seen here in this middle diagram, middle photo. And so he stated that epilepsy is caused by the sudden, excessive, and rapid discharge from this gray matter that caused a seizure. Due to the old idea of this disease being contagious, of spiritual origin, and related to some form of madness, there is a lot of stigma associated with epilepsy. And in many languages and many countries, these terms that should not be used are still being used by people, such as gila babi in Malay or in Bahasa Indonesia, right? And all this has got very bad connotation for epilepsy. Now, what are seizures? Our brain is composed of billions of nerve cells that generate electrical impulses so that we can control our thoughts, feelings, awareness, sensation, and movement. And when seizure occur, these normal electrical impulses are disrupted. So by abnormal excessive neuronal activity, right? So the normal activity is disrupted by abnormal excessive neuronal activity, which results in changes in movement, feeling, thought, awareness, and sensation. And this gives rise to the mystic nature of epilepsy because the patient cannot control his own feeling, thought, awareness, and sensation, and seem to be in another zone during the seizure attack. And what is epilepsy? Epilepsy is defined as having at least 2 unprovoked seizures occurring more than 24 hours apart. Unprovoked seizure means seizure not due to low blood sugar level, seizure not due to acute head injury or acute change in the electrolytes in your body. Why is that 2 seizures needed for definition of epilepsy? Because after a single first seizure, your recurrence risk is about 30%. However, if you have a second seizure following the first seizure, the risk of having the third and fourth seizure goes up to 70 to 80%. Thus, the definition of epilepsy. So in some patients, we can diagnose epilepsy even after one single seizure if, after assessment, we feel that the risk of having a second and third seizure is higher than 60%. So you don't really need 2 seizures to diagnose epilepsy. You may even have 1 seizure for us to make a diagnosis of epilepsy. What are the types of epilepsy? I will go through with you some videos of patients with epilepsy later. But what happens during a seizure? Typically, before a seizure, the patient may have headache, nausea, vomiting, or may feel tired. In some children, they might appear hyperactive or excessively quiet. During the seizure, when there is abnormal excessive brain neuronal activity in the brain, there will be a change in the movement, awareness, or sensation of the patient. Now, during the seizure, there is excessive neuronal activity, but most seizures stop on its own and last less than 5 minutes because the brain will try to stop the seizure on its own. There are some protective mechanism to stop the seizure on its own. And after the seizure, the patient may have headache, tiredness, or go to sleep. Some parents or teachers think that during this, what we call post-ictal period, the patient is still having the seizure because the patient is so tired and sleeping, they thought the patient is still having seizure, but actually the seizure has already stopped. And following the seizure, if the awareness is impaired in this patient, they will not be able to recall what happened during the seizure. When we classify seizure, we classify it as either of focal onset, meaning arising from one part of the brain, may be limited to the part of the brain, and it can also spread to another part of the brain. The other type of seizure is generalized onset, where the seizure starts from a circuit in both sides of the brain and rapidly spread. So this is what we call by generalized onset seizure. This is an example of patient with a focal onset seizure where he remained conscious. His right eye is open and the left eye closed, actually, with twitching of the left side of his face and the lips. And he remained conscious throughout this focal onset seizure, right? So it is not very dramatic to the seizure that we usually know. This patient is also has a focal onset seizure, but she's sitting down, appear in a daze when the technician tried to call her. You can hear the technician calling her, and she has got some movement in her arm, left arm. She tried to look at the technician but couldn't answer back when she was being called. There appeared to be a movement of the fingers, twitching of the left side of the face, some fidgeting and hand, what we call pill rolling of the fingers. And she couldn't respond to the call by the technician throughout this event, right? So she's having a focal onset seizure as well. This boy was sleeping when he had an attack of seizure. When he suddenly became stiff in the arms and leg, right? This is what we call a tonic seizure. This girl was also sleeping when she was having a seizure. And this seizure can mimic night terrors or bad dreams if you look at it carefully, where she starts with having thrashing movement, kicking movement of the leg. Her eyes were open and she appeared very scared, although I didn't show her face. She's fidgeting around, she's kicking. The right arm is in a what we call a tonic position. Right. So for people who are not aware, she may look to be having a night terror, turning, twisting around. Right? This is a patient with a focal onset seizure. And then she stopped. The next patient has got generalized onset seizure, where we were performing during an EEG recording, what we call hyperventilation process. And you can see that she's blowing to the tissue paper. And during this procedure, we try to bring out the seizure. You can notice that she suddenly stopped. And actually, during this period, her eyes were closed and she was not responding, right? So this is she's still having an attack now, right? So this is what we call an absence seizure and stopped. So, right? Absence epilepsy is the most common generalized childhood epilepsy. It occurs in children between 4 to 10-year-old and peaks at around 6 to 7-year-old, usually occurring in normal children, and consists of brief staring episodes, spells, sometimes with eye blinking, and they return immediately to awareness and activity. So in children in school, you may see them stopping their writing momentarily for about 2 to 3 seconds and then resuming to write, right? So they may be missed by school teachers or parents until these attacks become very often, maybe up to hundreds a day, when their school performance is also affected and start to deteriorate. And then only this seizure is recognized. This boy has got absence seizure as well, but with a component of myoclonic, meaning rapid, quick jerk of the body. You can see he's doing hyperventilation procedure during our EEG recording. And then he stopped the hyperventilation where there is some jerking movement of the shoulder. There goes again. So these seizures are not very apparent. There's very little motor movement and may be missed. See the very rapid jerking of the arm, of shoulder, and when he stopped hyperventilating, right? So it may not be very apparent to the people looking at him. Right? This girl has got absence seizure as well, but apart from that, when she closed her eyes during our recording, she has got flickering movement of the eyelid, just some flickering, this one. And this itself, during this recording, we found abnormal discharge in the brain during the EEG, right? So this consists of just movement, very little movement of the eyelid, and can be missed by teachers or parents. This boy also has got a myoclonic seizure, and we were performing what we call photic stimulation during a EEG recording to bring out the seizure. And that's what happened to him. Very rapid jerking of the arm, shoulders, and arm, and that's it. So this is a myoclonic seizure that is not very dramatic in nature. And this little kid has got what we call shock attacks, where she become limp and fall down. And that's it. That's the end of the seizure. If you watch it again, she was standing and then become loss of tone and then gets up. So that's the end of her seizure. So it may not be very apparent to teachers and parents. So there are many types of seizures in children. However, in most patients, they only have one type or at most two types. Rarely, in some difficult to treat epilepsy, they may have more than two types of seizure. And in children, the seizure types may change with age of the patient. Why are some seizures not recognized by teachers or parents? Because the dramatic tonic-clonic features that we commonly associate with seizures are not present in these patients. The staring episode or the termenung episodes in absence seizure can be easily missed, or the very rapid shock-like terkejut or head nodding in myoclonic seizure can be missed, or the jatuh or falls that we saw in the video can be easily missed, or when seizures occur during sleep, parents may think that those are bad dreams or night terrors. There are some triggers to seizure so that when you have this, patients with epilepsy are more likely to have the fit, such as flashing or flickering lights, lack of sleep, physical tiredness, emotional stress, or during illness or fever. And when we treat patients, we will try to ask them to identify whether there are any triggers and to avoid those triggers if possible. What are the mimics of seizures? The most common in children is syncope, or in Bahasa Malaysia, pengsan. Or the next is daydreaming. Some children has got bouts of daydreaming where they go like this, but can be easily distracted when their names are being called, and it lasts longer than absence seizure. Some children have abnormal involuntary movement called motor tics or stereotypies, and some patients may have psychogenic induced or stress-induced pseudo seizures. In the common vasovagal syncope or pengsan, which it is very situational and can be provoked, unlike epilepsy, which is unprovoked. Usually it occurs in a hot, crowded pavilion, astaka, after prolonged standing, or provoked by intense emotion. The patient may feel dizzy, sweaty, looks pale, or have nausea and blurred vision just before he falls down, become limp, and there might be some movement of the arms and legs, but very brief. And during this episode, when there is restoration of the blood flow to the brain, he regains consciousness rapidly and is able to recall what happened before the event. So this is the very common pengsan that we see in school. This boy has what we call tics, where you can hear him and see that he is conscious and just jerk his arms and momentarily. looking like a myoclonic seizure, but he's aware all the time, sitting and looking at the camera. Can see again. He's got this, right? And this is fixed, not seizure related. I've got permission from the parent of this boy to show this video of him having a stereotypy, children who has got hand flapping, finger fidgeting, mouth opening. A lot of children with disability also has this when they stop in their track and they do this, right? So this is stereotypy, but he can respond to call and usually triggered by excitement or boredom sometimes, right? You can see that he's opening his eye, opening his mouth, have some contraction of his arms and hand, but he's continue playing and circling around his toys. So this is stereotypy, which is common in children with disability. This girl was referred to us for epilepsy. You can see during our EEG recording, she starts to move her legs, shoulder, kicking, rolling her head left to right, kicking motion, jerking, looks like a fit, but it's bizarre. We don't see that in our patient with seizure. Then she stopped very abruptly, and then with what looks like myoclonic jerk of the shoulder and arms. But throughout the EEG recording, her EEG was totally normal. So this is pseudo seizure. Pseudo meaning false. Pseudo seizure is actually a paroxysmal non-epileptic event triggered by emotional stress and pressure, right? So this is not seizure, this is a pseudo seizure. I will next move on to the causes of epilepsy. In most patients, the cause is unknown in childhood. In those that are known, in 55% of patients, the causes include structural brain abnormality, genetic causes, metabolic, infection, immune, and trauma. Right? This is a patient who has got a brain abnormality. You can see that the brain of this one side of the brain is big, and the cortex, the gray matter, the place that causes seizure, is abnormal compared to the other side. So this patient has got a difficult to treat epilepsy due to a structural brain abnormality. And sometimes the abnormality is very small and can be missed, as in this patient with what we call a cortical dysplasia. Again, the gray matter is abnormal here as well compared to the other side. So if you don't look carefully, you may miss it, right? In patient with what we call also brain malformation, yeah, abnormal brain development, which causes this part of the brain to have excessive neuronal discharge. In immune-mediated, due to immune causes, patient may have one side of the brain affected and become smaller, and this also can cause difficult to treat epilepsy. When we talk about genetic cause, some disease, genetic disease, such as this condition, autosomal dominant, runs in the family, right? And this is the first epilepsy gene described, the autosomal dominant nocturnal frontal lobe epilepsy, runs in the family. And this girl has got a genetic condition that causes her epilepsy. She looks normal, but one of her chromosome 14, instead of the normal X shape, is in a ring shape. And this causes her epilepsy. This patient has got different facial feature from her sibling, with broad forehead, upturned nose, and very thin upper lips. She has got a syndrome called Melatica Syndrome due to deletion of a part of the chromosome, which also involve a gene, and the abnormal gene give rise to this brain problem. Smooth brain without much creases compared to a normal brain with a lot of fold, right? What we call lissencephaly. When we talk about genetic causes, the relationship between genetic cause and epilepsy is complex. Some genetic cause, the relationship is simple in single gene disorder, like I showed you just now, or in chromosomal disorder. But in many epilepsies, the cause and effect is multifactorial. The patient may have a genetic tendency, and together with other environmental factor, they will get epilepsy if the factors are correct. And the epilepsy can be mild or severe. There's a range of disease severity in patients with genetic causes. However, not all genetic cause is inherited because of spontaneous mutation occurring in the egg or sperm during meiosis, right? So not all genetic disease cause of epilepsy runs in the family. Although some patients may have some genetic tendency in the family, individuals in the family may have a low risk of getting the disease due to other factors that I mentioned just now. And because of this genetic tendency, this also results in stigma, like I mentioned before that. So in many childhood epilepsies of genetic cause, it is self-limited, but some are easily treated, although lifelong, but others are serious as well. And after brain trauma infection, you can cause epilepsy, but not in all. So people think that even after you get a brain trauma or brain infection, you may have epilepsy, and patient who has got this genetic tendency may be at more risk of getting epilepsy compared to patient who did not develop epilepsy. And epilepsy is not contagious. Just as a prelude to the next tomorrow's talk, the other comorbidities in patients with epilepsy is common. Learning problem in children with epilepsy, the rate is about 25%. Conversely, epilepsy in children with learning problem, like in special school need, can go up to 50%, the rate of epilepsy in children with learning problem. And there are various behavioral problems in children with epilepsy, such as autism, ADHD, school delinquency, and social problem in a study from Thailand. So in conclusion, epilepsy is a brain disorder where a person has recurring seizures, and not all seizures are tonic-clonic. Some seizures are subtle and can be missed. And the cause of epilepsy is found in only half of patients. Thank you for your attention.
Okay, thank you, Doctor. All right, now may I invite our second speaker, Dr. Koo Ching Soon, Consultant Neurologist of Hospital Chancellor Tuanku Mukhlis UKM, to start the lecture sessions. Dr. Koo, the floor is yours.
Very good morning to all of you. Can you hear me?
Yes.
Yes, sir.
Thank you so much. Yeah. So once again, very good morning to all of you. My name is Dr. Koo, one of the consultant neurologists from the National University of Malaysia Medical Center, Kuala Lumpur, Malaysia. And thanks to the previous speaker, Professor Wong, who has made a very brief and concise introduction to the Epilepsy Basics 1. So I'm going to tell you a little bit more on the Epilepsy Basics 2. I'll focus on epilepsy in adolescence. So for the delegates and participants from our neighboring countries, I would like to extend a warm welcome to all of you to Kuala Lumpur, Malaysia. I hope that you can pay us a visit sooner or later once the pandemic is over. So I'm an adult neurologist, so I would like to switch the focus from the pediatric populations to the adolescent population. So my focus will be on the epilepsy in adolescence. And of course, as a recap of what has been discussed and lectured by Professor Wong just now, just a little bit of terminologies. I hope that you will be made clear after this. So again, what is epilepsy and what are seizures? Epilepsy is a chronic brain disorder. And the very important feature of this brain disorder is that it is accompanied by recurrent and unprovoked seizures. So when we diagnose a person with epilepsy, they should have at least 2 unprovoked seizures or only 1 unprovoked seizure. And there's a probability that the likelihood of having the second or more seizures is high. And when we talk about unprovoked seizures, these factors or the medical conditions should not be some conditions that are known or reversible, such as alcohol withdrawal or extremely low blood sugar. And the seizure is a sudden surge or disturbance of electrical activity in the brain. And ladies and gentlemen, seizures are not epilepsy. Seizures are not a disease, and they are a symptom of many brain disorders, and one of those is epilepsy. So these are the very important terminologies that we have to make ourselves clear after this talk. And some seizures can hardly be noticed. So unless some of the seizures that would happen with the motor manifestations, that's what you have seen just now from the videos, some of the seizures are very, very difficult to notice when the changes are very subtle. So I'm going to have some videos later to demonstrate it. So the causes of epilepsy, as you can see from this picture over here, there are many, many. And the previous speaker has touched all these causes. And I'm just going to tell you, and just to as a recap, that one of the major causes of epilepsy is genetic. Either it is known or presumed genetic defect. Genetic cause is a very complex cause that is not easily explained by just one single gene, as you've seen from the previous lecture. It can be explained by many, many genes, and a lot of times we may not be able to identify a single gene that causes the epilepsy. So it is a very complicated and complex cause of epilepsy when we are diagnosing the patients. Moving on, structural. It could be either from congenital, meaning that the patient may have some birth defects from birth, or it could be acquired later in adult life, such as after suffering from a stroke or even a tumor. Immune is something is also very difficult and complex to explain. So to put it in an easy, understandable term or explanation is that the brain may suffer from the inflammation, swelling from a protein that alters the brain excitability, which could result in seizures. And a lot of times, not all, we may have some abnormal proteins produced from own body attacking the brain cells. Then the next important cause would be metabolism, meaning that there are defects in the metabolism resulting in the breakdown of specific substance in food that you eat that is impaired. So the buildup of these abnormal substances could affect the normal function of the brain, which could result later on in seizures. Infectious, not to miss that, because any brain infection potentially can cause seizures. And this is one of the very common causes of epilepsy in the third world. And even though we know these 5 major causes of epilepsy, however, there are still some causes of epilepsy that remain unclear or unknown. So types of seizures, Okay, again, generalized, focal, and unknown. I think you have seen this from the previous slides, from the previous speaker. So generalized, basically, it affects or starts from both sides of the brain. And the focal, as you can see from here, the red color, it starts from a particular, specific, or partial part of the brain that later will either remain there or spreads into the another side of the brain, which could also go into generalized. So we have these two types, generalized, which is on this left, and the focal on the right. And a lot of times, we may not be able to know the onset of seizures, which is also called as unknown. So now, after clearing some of the terminologies of epilepsy, now let us focus a little bit on adolescence. So why is that so important? Because adolescence, I think all of us know that this is a period of transition between childhood and adulthood. And I assume that most of teachers here, as the members of the talk, participants of the talk, are dealing with a lot of children, teenagers, school children. So you know how difficult it is to teach them, to educate them, more so if the adolescents have become epileptic patients. So this is a period which is very exciting, but again, very uncertain, because during this period, an adolescent undergoes a lot of changes in terms of physical, developmental, in terms of the brain and other organs, psychological, and also social changes. As we all know that we are very overwhelmed with a lot of social media nowadays, and all the adolescents perhaps, possess a phone, smartphone, that they can access many social medias. They make friends and a lot of social norms, new things, Wi-Fi's, hashtags, So they are very overwhelmed with all this information when they become adolescent. So what is the age of adolescence? According to the World Health Organization, WHO, it defines an adolescent as any person between the age 10 and 19. However, the age may differ among different countries, societies, and cultures. And the age is actually more important in assessing the changes in the biology. For example, reaching into puberty. So in other words, age is just a number and it doesn't represent the whole story. So ladies and gentlemen, to me, all these people are also teenagers. So teens with epilepsy, why is it so important? I think you have also heard from the previous speaker that incidence of epilepsy is high in adolescents. And because of the changes that they are experiencing, they are also having a lot of exigent issues, such as preparation for the university or employment. They start, trying to apply for a driving license, start mixing around, drinking. They would sooner or later have some social relationships, and also some of them are also preparing for some marriage and conception. So these are the issues that are related to teens with epilepsy. And a very important challenge, I would say, as clinicians, doctors, when managing epilepsy, is that they have started becoming very body conscious, and they didn't want to look different from the peer group. So that's a challenge when we prescribe some certain certain pills or medications to treat epilepsy, because some of the medications may have side effects such as weight gain or even hair growth. Stigma, they might not want to accept this diagnosis because they are young. They do not want to label or diagnose with a chronic brain disorder, and they do not want to be on pills. So these are all the challenges that we are facing when someone has an epilepsy during adolescence. And this stigma, I'm not going to touch more on this because I guess this will be taught by another speaker later on. So let us talk a little bit more in details in some common epilepsy syndromes that happen when they are young. So there are manifold again, but what I'm going to tell you today, and not to confuse all of you, that these are the 4 major types that we commonly see, or probably you will also encounter during your teaching years. So the first one would be a juvenile myoclonic epilepsy, in abbreviation JME, followed by juvenile absence epilepsy, JE, epilepsy with generalized tonic seizures, and last but not least, the temporal lobe epilepsy, in abbreviation TLE. So let us start with JME, again, juvenile myoclonic epilepsy. As the name implies, juvenile means young, yeah, junior and adolescent. So it commonly starts in adolescence, and it's a type of generalized epilepsy. As you remember the cartoon that I showed you earlier, it starts very abruptly, very fast from both parts of the brain, and you are not able to identify a specific focal part. And usually JME epilepsy patients will have a normal IQ, and they do not have any developmental problems. The hallmark of this epilepsy syndrome, epilepsy type, would be myoclonic seizures. So what are myoclonuses? So myoclonic seizures are, to put it in a layman term, and a more understandable term would be the brief shot-like muscle jerks, or in Malay we call it the sentak. This happens as if, if you remember when you're about to sleep or when you're about to wake up, you have this shock-like sensations very briefly. So this is the myoclonic jerks. But do not get me wrong, when you are about to sleep or when you are about to wake up and you have this myoclonic seizures, you have this myoclonus, it does not mean that you have an epilepsy. That is normal, that's physiological when it happens during sleep. What I mean is that the patients may have this myoclonic jerks, the brief shot-like muscle jerks, when they are at work, they are not sleeping, they are doing their routine, or when they're exposed to some certain strobes of lights. So this is the far most common type of seizure shortly after waking up. So there are also other seizure types under this syndrome, JME. You could progress into a generalized tonic-clonic seizures. Again, you've been exposed to this term, which is basically defined by the muscle stiffening, that means a tonic, and a clonic, which is the rhythmic jerky movements. And also absence. They could also have absence. So we keep talking about this absence. So absence, basically, these are the short periods of blank staring, blacking out moments that I will also talk about it later on the next type of the epilepsy syndrome. So again, the cause is genetic, and the triggers could include the following. And someone has some insufficient sleep or fatigue, alcohol binging, mental or emotional stress, and even when you go to disco, when you're exposed to some lights, strobes of lights, flickering of lights, that could also precipitate or trigger a seizure. So the next type will be the juvenile absence epilepsy, or in abbreviation JAE. Again, this is a type of generalized epilepsy, occurs at the adolescent age between 10 and 16. Again, there are no associated developmental problems. They look completely normal physically, and there are absence seizures in all cases. Genetic is the main cause. So absence seizures, I think, ladies and gentlemen, for the teachers, this is a very important, not to miss thing. I know that's very difficult even for doctors. So if you encounter any children who always stare into space or become unresponsive suddenly, or when their consciousness becomes impaired during class, do not scold them. You have to make sure that this is not a JAE. This could be a very subtle finding. I absolutely agree. But if you encounter, kids who do not pay attention to you, so this is one of the things that we need to think about before we say that, that the child is actually, having his own moment. So typically the eyes may roll up very briefly, or sometimes the eyelids may flutter. For JAE, which is a bit different from the childhood absence epilepsy, they last slightly longer, up to 45 seconds, but could end very abruptly. And it occurs less frequently, as what Professor Wong has mentioned in childhood absence epilepsy, where you can have many episodes in one day. For the JAE, it occurs less frequently, probably less than a day. And immediately after the fluttering or the flickering of the eyelids, the kid may resume the normal activity very fast after the seizure. And he or she is not even aware that something has happened. So these are the hallmarks that I hope that all of you could pay heed to when you encounter any kid having this presumed absence seizures. So the next type is the one that we usually describe, or usually we watch from the movies, the epilepsy with the generalized tonic-clonic seizures. As I mentioned earlier, the tonic means stiffening of the muscle, followed by the clonic, which is the rhythmic jerking movements upon awakening, which I'm going to show you again on my videos later on. So again, it's quite common in the teenage years. They usually have a normal development and also a normal IQ. And this is temporal lobe temporal lobe epilepsy, in abbreviation TLE. This is not a generalized form. This is a focal form, and is by far the most common form of the focal epilepsies. If you remember from the cartoon earlier, focal means there's a lesion or there's an abnormal discharge arising from a particular focus of the brain. So the common risk factors could include a previous prolonged febrile seizures, which means some kids between 6 months to 6 years old, when they have high-grade fever, they could have seizures for which the parents would usually bring them to the hospital. So if they have previous multiple episodes of prolonged febrile seizures or any injury to the brain when young, or any head trauma, this could lead to TLE later on. So they have some focal features, not just because of the brain that happens in a certain part of the brain, but clinically when we see the patient, there are some focal features such as the aura, means the patient may have some abnormal sensation of feeling. For example, they will suddenly have some stomach discomfort. They feel like they are on a roller coaster. They may have some deja vu feeling, as if they've seen something before, but they can't remember. And these are the warnings preceding the seizures. Amnesia, they tend to forget what has happened, and some movements of the mouth and hand, like some, the kind of chewing, lip smacking, turning head to one side, and some unusual posturing of the arm and fixed stare. And this could also develop into GTCs, generalized tonic-clonic seizures. So focal can develop into GTCs. So there are some imitators or mimics when it comes to epilepsy. There are many diseases that could look like seizures and epilepsy. This list is not exhaustive. I'm just telling you some of the common ones in adolescence. Syncope, Pangsan, or the fainting episodes due to various reasons. For example, in a hot, crowded environment, tiredness, lack of hydration, and so on. So this could lead to a faint, and sometimes we get to be confused whether this is an epilepsy or a fainting episode. Migraine, headache, unilateral. Sometimes the migraineurs could see some flashes of lights, and get very nauseous, and the headache could be disabling. Sometimes we could have some hard time differentiating between these two conditions. And psychogenic seizures, I think Professor Wong has told you earlier. Basically, these are not true epilepsy. So a lot of patients with the psychogenic seizures, usually they let off steam via different ways when they encounter or undergo a lot of emotional stress. So one of the ways that they would present to us would be seizures, seizure-like motions, or sometimes tremors. They will come into fainting, and they will have all sorts of neurological disorder mimicking manifestations. So this is very important not to miss, because we might potentially do more harm by prescribing the seizure pills to them. And they actually do not need the pills for epilepsy. What they need is actually counseling or a psychiatry referral. Tics, very brief movements or sounds, that I think that's also very difficult to differentiate, but these are the things that we need to know and when it comes to diagnosis of epilepsy. So like what this cartoon has shown here, this is actually an epiton, weight gained advertisement. I think when you pass by some express highways, you may see someone who looks like Donald Trump, but it's not. So these are the mimickers. So, ladies and gentlemen, after explaining some of the epilepsy syndromes, I think that's very important that some of you may have some questions how to diagnose epilepsy. I need to point out a very important thing is that diagnosis is it could be easy, it could be difficult. Diagnosing it, from our experience, is that it's usually a very daunting task, because there's no a single test that could firmly confirm the diagnosis. So a lot of times, the medical history, especially the history from the collateral history from somebody who witnessed the event, would be the most vital in establishing the diagnosis. So medical history is actually the foundation of the diagnosis. It's the most important. Say, for example, you got a history from the parents or the sisters or friends or spouse that could give us a very accurate account of what has happened to the patient, along with a video recording that would already be sufficient for us to diagnose epilepsy and start treatment. So what we need from you all, for those who have seen, for example, if you happen to see a kid or child fitting, please stay calm, record and tell us, nowadays you have all the smartphone, record it and tell us what has happened to the patient. That would be very, very crucial in establishing the diagnosis. Physical examination is important for us to look for any other associated clues. For example, some of the epilepsy syndromes may have some particular features, how the children look like. So these are very important to guide us which direction we are heading towards. EEG, which is the electroencephalography. It's an important tool to support the diagnosis of epilepsy. So basically what it does is that it records the brain electrical activity. So when we neurologists interpret, we will particularly look at any abnormal or normal electrical activities from that patient. And also, depending on the case, we might also need an MRI of the brain, magnetic resonance imaging. That's what is shown on the right upper corner, to look for any abnormalities in the brain. As you could appreciate over here on the left side of the brain here, there's a lesion here which looks smaller and brighter when you compare to the right side. So this is actually a hippocampal sclerosis, which is one of the causes of the temporal lobe epilepsy. So this is the cause of a focal epilepsy. So some words about EEG. So this is a relatively safe and painless procedure. It doesn't have any radiation risks, and the routine recording takes about 25-30 minutes, but it can be prolonged. For example, if you are unable to catch a seizure and we think that we need to have a little bit more information with the aid of the prolonged monitoring, we could sometimes extend the monitoring up to days until we could capture a seizure. So this is diagram on how the electrodes are placed and on the scalp. It doesn't need any surgery, any poking, any pricking thing. So it's completely painless. And we connect these electrodes with the wires into the computer, and we analyze the tracing of the electrical activity. So on the right below corner here, this is how the EEG tracing looks like. So we look at the entire recording and make a report of the patients coming with epilepsy or seizures. So for the next couple of minutes, I'm going to show you some videos, and hopefully with that, you could be able to appreciate some seizure patterns commonly encountered in our clinical practice. And I beg you not to record or take pictures of any of these videos. So first of all, I hope the video plays well. Okay, this is one of the patients who is monitored at the EEG lab. She's on a regular monitoring. You can see that she suddenly turns her head to the left, lifts her left arm, twitching on the left, elevates her right arm, okay. Stiffening takes place. And now it is followed by some very rhythmic jerking movements of four extremities. Okay, I just need to play a little bit faster. Okay, so the seizure activity stops, and now she becomes drowsy. You can hear some snoring. Okay, all right. So the next one. Okay, again, this is happening in the EEG lab. She's under monitoring. She's sleeping, during which we have already captured some abnormalities on the EEG. Okay, suddenly patient is caught opening her eyes, elevates her head, looking around. If you pay attentively, you could see some chewing, some movements of her mouth and lips. She just heaves a deep sigh and look carefully with the right hand. She's moving her hand purposely, like a coordinator in an orchestra. and stops. Okay. Then she wipes her nose and returns to sleep. Okay. This is a kid, probably. She's asked to count while we are monitoring her EG. As she counts, can you see? She stops and then she blinks her eyes. Okay, this is quite a long monitoring. I'm not going to show you all. So this is one of the types of the absence that I promised to show you just now. Okay, look at this patient.
Sorry, doctor. Sorry to interrupt. Doctor, you have another 2 minutes.
Sure.
All right.
Okay, so suddenly patient wakes up. She feels that something is not right, severe pain in the chest. And when we do the recording, she's actually having a seizure. So this is also a type of temporal lobe epilepsy. So you see, this could be very subtle. This patient just complains of chest pain without any jerking movements that you have watched from other videos. So ladies and gentlemen, we are coming to the end. So I think there is a lot of information that I think it is not possible to share within this 30 minutes talk. So these are all the websites that you can log on, you can browse through and try to get more information or detailed information if you're interested in epilepsy. So as I conclude, I would like to highlight again these few very important points. So epilepsy is a disease and seizures are the symptom. So the causes include genetic, metabolic, infectious, immune, structural, and a lot of times they are unknown. The incidence is high in adolescence. Some seizures can hardly be noticed, such as the very brief episodes of blank staring, blinking, and these are the common types of epilepsy that occur in adolescence. They are JME, JE, epilepsy with the generalized tonic seizures, and TLE. With that, I thank you for attention.
All right, thank you, Doctor. Okay, now I would like to invite our third speaker, Professor Dr. Fong Chung Yi, Consultant Pediatric Neurologist of Pusat Perubatan University of Malaysia, to start the lecture sessions. Doctor, the floor is yours. Thank you.
Very good morning, everyone. You all have had two very high-powered teaching sessions, right? So I think my talk now will be really a bit more relaxed. So don't worry, guys. Just relax, just enjoy yourself. But the first favor I need you all to do is turn on your videos one more time. I need to make sure you all are not asleep. Tak tidur, tak tidur. I don't know how to say in Thai or in Vietnam, but I want to make sure you all awake, eyes open. I need to do a bit of a warm-up exercise just to make sure all of you are awake. Okay, I see some of you there. Very nice background there. Okay, very good. Because the timing is very tight, the organizer said I cannot go more than 30 minutes my talk. So we do a very quick warm-up session. In Malaysia, one of our popular fruits is coconut. I don't know whether you have coconut in Vietnam, in Thailand, but must have lah. It's a Southeast Asian fruit, isn't it? So what we're gonna do, okay, guys, you can hear me. Hear me, thumbs up. Can hear me, thumbs up. Thumbs up, good. Okay, we're gonna go and find a coconut. We're gonna cut the coconut and we're gonna drink coconut juice before my talk. Okay, first of all, kita cari coconut. You can go find a coconut. Can you look for a coconut? Find a coconut. Find a nice coconut, big coconut. Hold it. Can you hold it here, right in front of you? Okay, now this very nice coconut, we're gonna cut it with parang. In Malaysia, a knife is called parang. I don't know what you say in Indonesia or Vietnam, but parang is a strong knife in Malaysia. One time we cut it. Wacha. Can we do a wacha cut? Okay, we have 2 coconuts here. Okay, 2 coconuts, make sure got a lot of juice, a lot of juice. Okay, 1 coconut, now we drink. Are you drinking your coconut juice? Very good. Coconut is very healthy. Okay, everyone's awake. Everyone's awake. Okay, so now I'll start my talk. Okay, I'll start my talk. You want to turn off your video, it's okay, but you can turn on your video. It's always nice to see your face too. Now, okay, you can see my presentation. Okay, yeah. Okay, let me just the title of my talk for the next 30 minutes is Treatment of Epilepsy. And this will be a very basic talk for everyone. How I will take you through my talk is, first of all, we will try to highlight to you, and this is the whole purpose of this webinar today, is to improve your awareness of epilepsy. And we know teachers are so important. You play such an important role in our young generation's life. Yeah. And then I will share with you epilepsy treatment, the aims of the treatment, the types of epilepsy treatment that we use. And then finally, I will end my talk by stating what sort of safety advice, first aid advice that we give during a seizure. Okay. So first of all, the importance of epilepsy education. You know, in Asia, and Dr. Sharini will probably talk more about this later, you know, there is a lack of awareness of epilepsy. A lot of people are scared of epilepsy. There is limited knowledge, there's false belief, there's negative attitudes among the general public towards patients with epilepsy. And we know that the school years are very important period for children with epilepsy in their social and psychological development. And we know that the child with epilepsy have a lot of contact with their teachers and their friends in school. And we know during this COVID-19 pandemic, during the lockdown in Malaysia, children with epilepsy have had a lot of stress. They were not able to go to school. They were not able to interact with their teachers and their friends. And that shows just how important going to school is for these children. And we know that having a good knowledge, attitude, and awareness of epilepsy among the teachers and their friends, the students, is also very important. And epilepsy education is an important treatment arm for management of epilepsy, because it provides medically accurate information. Because right now, a lot of information put online is not necessarily real news. A lot of them are in fact fake news, okay? And with this accurate education, you can address potential misperceptions. So what we did in Malaysia, we wanted to evaluate this, okay? So we developed an epilepsy education program with our collaborators in Terengganu, you know, because, you know, in our clinic it's busy, and we wanted to deliver epilepsy education in a quick way, but an accurate way. So we developed a program, you know, and all our parents will go through this program. There will be 9 sections in this program. They'll know what is epilepsy, safety tips, you know, first aid, dealing with epilepsy. In fact, a lot of what you're learning today is in this program here. And it takes around 20 minutes to complete. So what we did, we also ran this among our secondary school teachers and students. And because we thought it'd be interesting to see what the baseline awareness of epilepsy is among our teachers and students there. So in our Wilayah Persekutuan Teachers Day in 2015 and 2016, we ran this program among our teachers and students there. And we've published these findings here. You know, 54 teachers and 67 students participated. We assessed their awareness of epilepsy, their knowledge of epilepsy, their attitudes of epilepsy. And as you can see in this graph here, this is before we showed the program, and this is after we showed the program. You can see among the teachers, the awareness of epilepsy among the teachers were low before the program. Yeah, and after we taught about them, it went up to moderate. What was important also was the knowledge component. Before the program was moderate, a level of knowledge component, and went up to very high after they ran through this program. And the same thing with attitude. The good thing was all teachers were positive about epilepsy, but this again also increased to a higher level of very positive. And what was also interesting among our students, They have even worse, not surprising, awareness of epilepsy. They were very low. They had worse knowledge. They had low knowledge of epilepsy. But when we implemented this program, it went up to very high. And also very nicely, we showed that, attitude, before they did this program, they were indifferent. Neither here nor there. They were neither positive or negative about children with epilepsy. But after this education program, it went up to very positive. Yeah, and these findings were also shown among our parents with epilepsy, where we showed that we can also increase their awareness and knowledge of epilepsy using educational programs, and we improve their quality of life of the children, when we improve their knowledge. And so what we are trying to do now for our children with epilepsy, we're trying to develop a more fun way to know about epilepsy, and this is what we have just developed. So we're trying to develop, other ways of delivering epilepsy education. For kids, we're trying to find ways to make it more interactive for them, in a fun way. And basically, what the studies have shown, especially in Malaysia, is shown how epilepsy education is so important to improve the lives of these children with epilepsy, the quality of life, because it helps provide accurate information, prevents misconception, improves the knowledge, awareness, and positive attitude to epilepsy. And that's one of the reasons why we're conducting webinars like this, to help improve the knowledge among school teachers too. So now the next part of my talk will be talking about epilepsy treatment. And the primary aim for epilepsy treatment is to control the seizures and reduce the risk directly related to seizures, the injuries or accidents that may occur due to seizures. And sometimes in prolonged seizures, you can get risk of brain injuries, and rarely sometimes this can be severe and can cause death. An old study, showed that in individuals with epilepsy, the risk of injuries increase if the seizures become more frequent, certainly more than one convulsive seizures per month. As you can see from these bar charts here, if you have more than one seizure a month, your risk increase for having head injuries. 32% here have head injuries, 11% have burns and scars, and we still have patients, in the kitchen when they have a convulsion, they have burns, all splatter onto their face, and they can have injuries there. Some of them can have dental injuries, like what this graph shows here, and other injuries too. So it's a real problem, and treatment of epilepsy reduces this injury risk. You may still think that it cannot be serious, yeah, but we know that patients can die from epilepsy. For example, in Malaysia, we had a Nigerian PhD student died of seizure while asleep. Another patient died drowning during a seizure. And of course, some of you may know, Cameron Boyce is a famous Disney actor, also died from sleep due to seizures. So epilepsy is not something that you should take lightly, and there's real risk of injuries to it. The other aims of epilepsy treatment are also to reduce long-term effects of epilepsy. We want to try to reduce the potential decline in academic and learning performance. We want to try to reduce the negative impact epilepsy can have to physical, psychological, social, emotional development. And it's a real problem, because we know that, parents still come to me saying that, Dr. Fong, in school, my teachers don't allow my child to do physical education. Mereka tidak boleh buat pendidikan jasmani, physical education. And it's heartbreaking, because these kids want to do physical exercise, but the school environment does not allow it, and this having reduced physical exercise has an impact on their self-confidence. They cannot participate in social activities. They're not able to make friends, and often this leads to having behavioral difficulties, depression, increased anxiety. And all of this have a negative impact on school attendance and participation in recreational activities. The other possible long-term effect is that if we do not control these seizures, the seizures may make the epilepsy more difficult to control. So it becomes a vicious circle. Repeated untreated seizures can make the epilepsy more difficult to control. So in summary, in terms of the aims of treatment of epilepsy, first of all, to reduce the risk of accidents, injuries, and possible death due to seizures. Secondly, to reduce the negative impact to development and learning in the child. Thirdly, to allow the patient to have a healthy physical, emotional, and social development like his friends or her friends. And finally, to prevent the epilepsy from becoming more difficult to control. Ultimately, what we as doctors want when we treat these children of epilepsy, we want the child to experience as normal a childhood as possible, to experience as full a school experience like other children. We do not want these children to be labeled as someone with epilepsy that cannot do anything. We want them to still lead as normal a life as possible. So I will now focus on the second part of my talk, is epilepsy treatment. And what type of treatment that we give, And the first thing that's always important is not medicine. The first thing that we always advise all children with epilepsy is to have a healthy lifestyle, and then to try to provide individualized support to the child and family. And then after that, the main treatment of choice we use is anti-seizure medication. Yeah, there are other treatment choices like epilepsy surgery, special diets like ketogenic diet, special devices like vagus nerve stimulation. But don't worry about that. That we don't use that in majority of the patient. By and large, the first three arms are what we do, and I will talk more about that now. In terms of healthy lifestyle, in Malaysia, I can tell you a lot of our children are not sleeping enough. I'm sure it's the same problem in Vietnam. I'm sure it's the same problem in Thailand. The children that come to see me, the first thing they have is they watch too much TV programs. In Malaysia, we have things like Astro, and there's more than 3 TV channels. In the past, during my time when I was young, there's only 3 or maybe 4 TV channels. Now there's 30, 40, 50 TV channels for children to watch, and that's a big problem, and I always say, are they watching too much TV? The second thing is they may say, Dr. Fong, I'm not watching TV. The next thing I ask, do you play a lot of video games like PlayStation and so forth? They may say, no, I don't play much PlayStation or video games. The next thing I will do is check their pockets. And before you know it, all of our young children have phones in their pockets. And that's a problem, because I know if they have phones in their pockets, they're playing too much phone. They're having too much screen time. And I always try to advise them to get enough sleep. That's really important. Yeah, certainly need to have at least 8 to 9 hours of sleep, because I can tell you a lot of our Malaysian children are sleeping too late, 10, 11, 12 o'clock at night. Yeah, I also advise them to reduce prolonged screen time to maximum recreational screen time, 2 hours per day, or even less whenever possible. I always try to encourage physical exercise, recreational social activities, and that's where the school authorities come in, to try to help encourage them to be active, have a healthy diet, for the teenagers, young adults, avoid smoking, avoid alcohol, and learn to manage stress. In terms of medication itself per se, there are many types of medication. Broadly, there are tablets and there are liquid preparations for the medication. The types of medication I choose based on their type of seizure, as what the earlier 2 speakers talked about, and the age of the child. Often this medication needs to be eaten twice a day. Sometimes they need to take it in school, and we advise parents to advise their teachers if this is the case. And often for children, they may need to take it for a few years, usually for 2 years. Yeah, but what I want to highlight to you is that majority of our children with epilepsy, 70% of them, by taking the right medicine, will be seizure-free. And that's very important to note because a lot of teachers worry. They say, oh, if this student's taking medicine, the chance of him having seizure in the classroom is very high, and everyone gets very worried. That's not the case. In fact, most of your students with epilepsy in school will not have a seizure if they're on the right treatment. 70% of them will be seizure-free. How does anti-seizure medicine work? And basically, it broadly works by improving your chemicals in your brain. Because in your brain, there are two broad chemicals. One that cause excitation, excitatory chemicals, and one that cause inhibition. What happens in seizures is that there's too many excitatory chemicals in the brain, and that causes seizures. And what we try to do is try to get the right balance. Reduce excitation in the brain, excitatory chemicals in the brain, and this prevents seizures from happening. When do we start our children with medicine? If they have frequent seizures, as I've shown you before, if it's more than a few times a year, patients who are at risk of complications of injuries from convulsive seizures, if the seizures affect their ability to learn and socialize, if the quality of life of the child and family are affected by seizures, and that's when we start them on medicine. In terms of emergency medication to stop seizures, if the seizures are prolonged, and when we say seizures are prolonged, if the seizures are more than 5 minutes, so these parents will be given either rectal diazepam. These are medicines that we give through the bottom, the backside, if the seizures are prolonged, and that's what most of our parents have. Some parents will have what we call by buccal midazolam. This medicine, emergency medicine, is given through the gums if they have prolonged seizure. Overseas in the Western countries like Britain, Australia, teachers are allowed to give emergency medicine if they have prolonged seizures. In Malaysia, unfortunately, our teachers are not allowed to do so. So what sometimes happens is that the parents put the emergency medicine or provide the teachers with the emergency medicine in a safety cabinet. And if they have prolonged seizures, the parents will then come to the school and administer this medicine. This is something that we're still trying to work around to see how we can empower teachers to be empowered to give this emergency medicine too. In terms of safety advice for all children of epilepsy, what I want to emphasize is that overall, the risk of children with injuries are small, and simple strategies can reduce the risk of injuries without having an effect in the child's lifestyle. And this is really important because we want the child to experience a full childhood. A lot of members of public feel that if you have epilepsy, you cannot swim, you cannot go camping, you cannot do team sports like taekwondo, like football, and ultimately when you become adulthood, you cannot drive. And this is all wrong. With the right strategies, we can correct this and allow our children to lead a full childhood. So the broad safety advice, the first thing I always tell parents, they need to communicate with their school teachers about the disease in detail. They need to tell teachers what may trigger the seizures. Sometimes bright light, sometimes certain things can trigger the seizures. Tell the teachers what signs the child may show during a seizure and the type of seizure. So, as what the two previous speakers have shown, sometimes, just stopping what you're doing, having repetitive eye blinking, that may be a sign that the child's having a seizure. And then also to provide guidance of what emergency action that the teacher can do during a seizure and when should we consider to give emergency medication. And this is important here because a lot of parents that speak to me, they say, Dr. Fong, I'm very worried to tell my teachers that my child has epilepsy because they worry that if they tell the teachers that their child has epilepsy, the teachers may discriminate them. They may restrict them from doing specific activities. And this is very important because for teachers to understand this and understand the teachers' fears. And we want to highlight this to you all so that you all can have an open mind to epilepsy, be more aware about it, and it can have open communication with parents to see how we can help these children with epilepsy in school. In terms of lifestyle advice, we always say that children of epilepsy are encouraged to participate in sports and outdoor activities with specific precautions. Generally, they can participate in almost all activities like other students. Things like football, camping, uniform activities, that's not a problem. So long as the teachers know some safety advice, first aid advice, on what to do if the child has a seizure. Specific precautions, things like contact sports, certain sports like cycling, they can wear a helmet just to protect them in case they fall during a seizure. They need to be accompanied for certain activities like cycling, swimming, or water-based activities to make sure they don't get injuries or they don't drown, for example. But they can still participate, but someone there needs to know first aid skills, needs to be aware that this child has seizures, and to just be vigilant during the activity. What they cannot do is they cannot participate, if they have active seizures, cannot participate in activities of high heights, things like rock climbing. That's what we discourage. And overseas, that's a big thing, things like abseiling, rock climbing, that potentially is too dangerous for the child. Scuba diving, that's another high-risk activity that we discourage, because if they have a seizure deep in the ocean, no one can save them. But by and large, what I want to highlight is that it's very important that students with epilepsy are not discriminated. There are still schools where students are not allowed to do sports, not allowed to do outdoor activities. And that's something that we really want to try to empower teachers and school authorities to allow, because they can still do a lot of these activities. In terms of other precautions, things like precautions during class activities that may cause injuries, like lab experiments, cooking classes, just take precautions there. Avoid sitting beside a glass window. If a child's going to the bathroom, avoid locking the bathroom door when alone. And for at home, we often advise them, if they want to take a shower, clean themselves, use a shower but not a bathtub. In Malaysia, we don't often use bathtubs, but overseas that's a big issue, because you use bathtubs to clean yourself, to wash yourself, you have a risk of drowning. In terms of other lifestyle advice, we always say, always eat your medication at the right time. If you have frequent seizures, sometimes we ask them to wear an epilepsy bracelet or some form of epilepsy passport or epilepsy, just a piece of paper to put in their wallet, in their handbag, with emergency phone contact details in case they have a seizure in public, they lose consciousness and members of the public find them, and they know who to contact. In terms of first aid advice, we always tell teachers, don't panic. When you see a child with seizure, look at the clock to know when the seizure starts. Then move the patient away from a dangerous location, away from any corners where they can injure themselves, away from, any sharp equipment, electrical equipment that they may injure themselves, loosen their collar. And the first thing we always say, don't put anything to their mouth. That's still very common. I find parents, someone say, oh, doctor, when the seizure happened, I put my finger in the mouth. I found a spoon, put it in the mouth. And that can cause more injuries to both the witness and to the child. Don't put anything in the mouth. Gently hold the patient, but do not restrain them. Do not suffocate them. We still hear stories of children sustaining injuries because they're being held too tightly. Members of the public are trying to hold them down, and they can get skeletal injuries, bone fractures, and so forth. Just hold them gently, but do not restrain them. Put them in a recovery position to the side. And if the seizures are more than 5 minutes, to give emergency medication or to alert someone, call the ambulance, quickly call parents to administer the emergency medicine, if the seizures do not stop. So actually, this is a summary of my talk. I hope it's a very basic talk, but I hope you found it useful. I think the first thing I hope I've highlighted is the importance of teachers to have a high awareness and positive attitude to epilepsy. I hope I've shown you that majority of children with epilepsy can be fully treated with the right medication. And I hope I've emphasized to you that students with epilepsy should not be discriminated. Simple strategies can reduce the risk of injuries from seizures without affecting their child's lifestyle. And I hope I've highlighted to you that students with epilepsy should be given the opportunity to fulfill their full potential and to give them every chance possible. This is the end of my talk. I'd like to thank the organizers again for allowing me to talk today. Let me stop my sharing.
All right, thank you, Doctor. Okay, now let's proceed with our last speaker for today. And I would like to invite Dr. Sharini Badir Ahmad, Consultant Neurologist of Subang Jaya Medical Center, to start the topic on epilepsy and stigma. Doctor, the floor is yours. Thank you.
Oh, hi. Can you hear me now?
Yeah, sure.
Sorry.
That's okay.
I'll share my screen again. Joining us from Malaysia and also our neighboring country. So my talk will be surrounding stigma issues in people with epilepsy. You may find there are some overlaps with the previous lectures, but we are going to talk more about or elaborate more about stigma in epilepsy. So let's start. A bit of a statistic. 65 million people around the world live with epilepsy, and nearly 80% are found in developing countries, including Malaysia. Approximately 200,000 Malaysians were diagnosed with epilepsy in the year 2004, and this is not a small number. So someone you know is living with epilepsy. Some of the epilepsy facts, so about 70%, like Prof Fong has spoken to you, that about 70% of epilepsy can be well controlled with medications alone. There is no age, racial, national, or geographical boundaries when it comes to the diagnosis of epilepsy. The disease itself can cause profound physical, psychological, and social consequences. There is a high risk of comorbidity and premature mortality if seizures are poorly controlled. Epilepsy can cause misunderstanding, fear, secrecy, stigmatization, and social isolation. You've heard from all our three speakers. Each time when they give a talk, they always speak about stigma surrounding epilepsy. It is a highly stigmatized disease. Misconceptions and prejudice lead to rejection and isolation, i.e. discrimination. Epilepsy itself carries a heavy burden to individual, family, and society. Now, before we talk about stigma, it is quite interesting to know, what do we mean by stigma? What is the definition of stigma? So the concept of stigma has been described by a famous Canadian-born sociologist, Irving Goffman, in his book. Now, he described it as an extreme disapproval of a person or group on socially characteristic grounds that are perceived and serve to distinguish them from other members of society. So society then decides or conceptualizes what constitutes differentness or deviance from social norm, resulting in subsequent applications of rules and sanctions against the person so labeled, i.e. discrimination. Now, what does this mean? To put it in a simpler way, so the society decides, so you and me as part of society, approve a standard of behavior. And what do we mean by that? So how you act, how you appear, what you can say, what clothes you wear, how many legs people should have, how many fingers people should have, do you carry good genes or bad genes? So for those who do not meet these standards, they will then conceal themselves or their identity or their disease in the fear of being discriminated or rejected or discredited by the society. Let me give you an example relating to epilepsy. So what society thinks about epilepsy in general. So before you come to this lecture, maybe people think that all epilepsy patients have low IQ, which is not true. But this may be something that society has labeled people with epilepsy. And what then society decides? So if you say that all epilepsy patients have low IQ, then automatically you would think that children with epilepsy will be slow in your class, will not succeed, you should not invest on their success at school, no potentials, and they are unable to carry out responsibilities. They essentially has been sort of like looked down compared to their peers in school. As a consequence, so they won't be accepted in certain school or workplace, like what Prof Fong has mentioned before. They're not able to hold certain positions, such as being a leader, being the school prefect, joining some competitions. And this will make them ending up not having many friends, socially unpopular, unable to get a job or succeed in a job interview, can't get promoted, and their potentials and skills would just being overlooked just because of label that we have given them. And what happens? They then conceal their disease. They hide their disease. They skip their medications because they don't want to be caught taking medicine and being asked questions. They will then miss their doctor's appointments, continue living in fear of being judged by society, having low self-esteem, become an introvert, and self-isolate. So what I've shown you essentially is, number one, how stigma appear in a certain condition is that what society thinks, the label that we give is very important. And this can cause negative stereotype and oversimplified generalization on patients with epilepsy and causing division or prejudice, dividing them between people with epilepsy and people without epilepsy, causing them to lose their social status. And then they get discriminated by concealed stigma and self-isolation. So what do I mean by concealed stigma? So epilepsy is a discreditable condition whereby the stigma attached to it is not immediately apparent or known. And discreditable, i.e. concealed stigma, the stigma or negative attributes or stereotype attached to it is actually hidden. So if you look at this tip of the iceberg way of explaining how things may be overlooked, so if you look at people with epilepsy, what the general public see is, okay, someone have epilepsy, they have seizures, you could see the physical appearance of someone having seizures, which you have learned today. But what people don't see are the stigma, the burden that is deeper and bigger attached to people living with epilepsy. We start with living with the disease, which is the internalized stigma. Having the disease itself already carries such burden to them. They are prone to injury. There's also the medication burden. Side effects of medications can alter their self-image, cause them to be tired, poor attention and memory. They will miss classes because they have to keep up with their hospital appointments, having sick leaves. They may have learning problems. This is such a big responsibility and burden to be put on someone as young as in primary school, let alone going to secondary school, having more responsibilities. And then there's also social stigma. What is social stigma? The attitudes, the negative attitudes that society has on them. And it doesn't have to just come from society. It can be from even family members, negative attitudes about someone having epilepsy. It could be negative attitudes coming from school, their workplace, their spouse or their partner. And this can cause social discrimination, the actual discrimination that happened on patient, what we call an enacted stigma, causing them to be unemployed, being denied opportunities in life, banned from school, barred from marriage, unable to drive, and causing them to lose their independence. And of course, don't forget about mental burden of having the disease, the felt and internalized stigma, causing them to have low self-esteem, self-isolation, depression, and anxiety. And we always talk about epilepsy and patient, but how about their support system? Don't forget about the stigma that goes to family members, spouses, and carers. These are called the courtesy stigma. And people looking after emotional, physical, financial, and also social discrimination. Now, when we learn about stigma, I think it's quite good to look at history. How does stigma evolve over time and how does misconception evolve over time? I think Prof. Sawe has mentioned about the origin of the word epilepsy. So epilepsy comes from a Greek verb, epilambano or epilambanin. It means to be seized, to seize upon, or to be overwhelmed by surprise. Now, different part of the world will have its own terminology. Prof. Wong has actually shown you some of the terminology used. Now, let me give you a simpler way of explaining this. So when you choose a name for your child, you probably want to choose the best name with the best meanings. You don't want to give them names that are derogatory or discrediting. This is going to cause them to be ashamed of revealing their names in the future. They may end up changing their names when they grow up. So that's the same thing of labeling or giving a name to a disease. even the language used to describe the epilepsy itself is already derogatory and discrediting. Let me bring you to 2,000 years ago, when there was an ancient Chinese writing, Huang Di Neijing, describe epilepsy under two terms, which is Dianji and Xian, Dian Xian. Dian is eventually associated with madness, Ziu Qi Gan, i.e. shamefulness. The Ming Dynasty Dictionary described epilepsy as a disorder of internal organs secondary to wind and associated with different kinds of animals, for example, goat and pig. We are not far off either, because the Malay describe the act of having a seizure as sawan babi or gila babi. I think that's really derogatory. And in Norway, they call epilepsy as an epileptic insania epileptica, epileptic insanity, which is madness. Vietnamese used to describe the act of seizure as dong kin, which is moving terribly. So these are not nice names. This is another example. You can see that almost half the page is talking about madness when it comes to describing what epilepsy is. And these are the language used in various part of Asian countries. And you could see here that epilepsy also has been described as mad pig disease. Can you imagine having to live with this diagnosis, with this label for the rest of your life? Now, the second thing about epilepsy and stigma is the belief that epilepsy is due to the evil spirits and possessions by demons. Now, you have seen my colleagues showing you the video of people having seizures or having fit attack. And it is not surprising why the sudden and dramatic seizure attacks has been associated with many mystical and misconceptions. This picture here showing a priest trying to cast out demons that were thought to cause epilepsy in this person here. Throughout history and in almost every culture, epilepsy has been viewed as something to be feared, avoided, and concealed. People with epilepsy were regarded as being chosen or being possessed. Epilepsy being attributed to ghosts and demons or bad spirits. There were people who believed that the disease is sacred and is a divine punishment by God. Now, Prof. Wong mentioned about the Mesopotamian time where there were laws stating about epilepsy. At that time, they describe epilepsy as the falling sickness, or they call it the miktu. And this is a cuneiform tablet. It's basically a piece of stone that they engrave, and on these stones is like their books. You know, they sort of write all the laws relating to the current government or state that they have at that time. And these laws were actually enacted by King Hammurabi. And it actually covers social status, slaves versus free men, man versus woman. And epilepsy has been, the law on people with epilepsy has already been laid down even 2000 before Christ. So miktu or seizures were attributed to the hands of sin. If a person has a single seizure, he will live. If he has 2 to 3 spells a day, he will die. And most importantly, they already labeled that this is a negative thing. So people with epilepsy or miktu could not get married, could not testify in court. And even if you are a slave, if you have epilepsy, you can't even be a slave. So in the Christian world as well, epilepsy has been associated with evil spirits. A child with seizures is thought to contain a spirit of dumbness. And this is again showing a priest trying to cast away the demon, the unclean, dumb, and deaf spirit from a child who's thought, who's actually having a seizure. And in the Arab Persian manuscript as well, Zoroaster, who's an Iranian preacher, associate epilepsy with evil spirits. So people who suffer from epilepsy are actually prohibited from offering sacrifices in his honors. So that's what people used to believe about epilepsy. Now, the next one is believing that epilepsy is contagious. People used to spit at a person with epilepsy and refuse to use the same dish. You have learned from my colleagues today what causes epilepsy. There's nowhere in there that my colleague have mentioned that epilepsy is contagious. In a 13th century German preacher wrote that epilepsy can be passed on to another person through a patient's evil breath. So there was even a saying there, neither talk nor bath with him, since by their mere breath they infect people. Not far from us, in Laos, epilepsy used to be thought to be transmitted through saliva, hence patients not encouraged to eat together at the same table with other family members. And we know these are all myth, misconception, and not true at all. Epilepsy is not contagious. When you have all this mystical belief and misconception, of course, the treatment can be a bit bizarre as well. So if you look in the 1918, this lady is actually draining her blood out. And this is thought to be a cure for epilepsy. In fact, these days, even when someone has stroke or angin ahma, they tend to sort of bleed themselves and as a way of maybe curing the stroke. So drinking humans or animal blood was also frequently used as a treatment method. And this is just a picture of someone making a hole on this man's skull to get the evil spirit or the demon out of the brain of a person having epilepsy. This is another bizarre way or beliefs. If you wear this magic satchel around your neck, which has powerful ingredients, then you can be cured from epilepsy or not get epilepsy. And you see this child here is being shoved or pulled through a natural opening in the tree. And this is thought to cure epilepsy. How bizarre. Until about 400 BC, when someone actually starts saying something pathological, which is Hippocrates. He's a Greek physician, and he's also been called the father of medicine. And he says that epilepsy is no more divine than other disease. He said that it is hereditary. It lies in the brain. And epilepsy should not be treated by magic, but by diet and drugs. We know now from my colleague's lecture that not all epilepsy is hereditary. Yet his view failed to become widely accepted for hundreds of years. In 1870, Hewlin Jackson, who is a famous British neurologist, maybe father of epilepsy, described epilepsy as a sudden, excessive, rapid, and disorderly discharge of cerebral nervous tissue on muscles, which is not far off from the current definitions that we have now on epilepsy. And of course, we have evolved over time. These days, we know now what epilepsy is all about. We can diagnose epilepsy by various means, by history taking, by investigations, using scans such as MRI or CT to look at the brain, and many other fancy ways of looking at the brain. We can actually look at the brain waves, and thank God we don't have to shove anyone into a tree to cure epilepsy anymore, because we have medications these days to help cure people with epilepsy. And well, not so much of drilling a small hole, but big holes, okay? So now not everyone needs epilepsy surgery, but for those who need, we have neurosurgeons here performing epilepsy surgery. You can open up the brain, you can look at where the source of the epilepsy is, and you can remove the abnormal brain out to cure someone from epilepsy. And also there's devices that can be used. So how we have evolved over time. But Hewlin Jackson also said it takes 50 years to get a wrong idea of medicine and 100 years a right one into medicine. So after centuries of learning and correcting misconceptions on epilepsy, we still have people who still believe that epilepsy is the act of evil spirits and demons, and also maybe a punishment from God. Now, we still have people who do not seek medical treatments, but instead goes to Bomo and shaman, getting traditional medicine, going through sacrifices and exorcism. Now, we do not blame people going for priests to the priest or ustaz for a religious way of treating epilepsy. In fact, if that's what our patient believes, we try to work hand in hand with the priest and ustad possible. But what we ask for is do not let go of the medications that we give. You know, we all believe in our own religion and we can combine them, but be careful. Everyone these days wants to be Bomo and shaman. You don't want to end up in a place where someone start to dance around with a coconut on their head and trying to tell you they can cure epilepsy. Remember, scam alert. It involves a lot of money. That money is better off spent somewhere else. So what I have spoken today is that we have described about how society and cultures and beliefs has shaped or labeled epilepsy, and this has been associated with negative stereotype and causing division among people with epilepsy and society, causing them to lose their social status, and of course causing discrimination. But don't forget, power is an important factor in creating stigma. It is an important component in the social production of stigma because only people or group who possess social, political, or economic power can impose their cognitions about a particular condition or stigmatization. What does it mean? This is your policymakers, the government. Now, we don't have to talk big. Let's talk about school. Like Prof. Fong has said, there are rules in the school. Epilepsy patients can do this and that. So if you are the policymakers for your school, if you are running your school, you are the power. So what is the school ruling? After today, what is your school ruling in terms of treating students with epilepsy? Are they allowed in your school? If they're not allowed in your school, why? Is it because of fear of their disease, or is it because they really need a special school? And what are the things they are allowed to do? What are the things that they're not allowed to do? And in the workplace, for example, today may not be just about students with epilepsy. You may have your colleagues, teachers who also have epilepsy. Now, how do you treat them at the workplace? What job can they do? What job can they not do? Do you look at their potentials? Do you look beyond their disease and actually look at their potentials? So your understanding of the disease is very important because you're holding the power. Let me just give you an example. So until December 1999, India was the only country in the world with an absurd law on epilepsy and marriage. So if you were going to get married, you have to make sure that you do not have any attacks of insanity or mental illness or epilepsy. It took a struggle of 12 years for the Epilepsy Association to have the word epilepsy deleted from this law. Seizures currently no longer a condition to claim for divorce. It used to be. Now, have you heard of this eugenic move? Maybe some of you have heard of this. It's such a big historical moment and left a big scar to a lot of people with ethnic diversities, gypsies, people who are disabled, including people with epilepsy. Eugenic is a movement developed in the 19th century, which went on to the 20th century. It was first started by this statistician, Francis Galton. His idea is to improve human race by selective breeding, i.e., if you possess good genes or traits, you are allowed to live in this world. But if you have bad genes, if you're gypsy, if you're disabled, you have one leg and not two legs, you have epilepsies, you have anything that you can, bad traits of genes, then you should be killed or eliminated. And it went on for quite a long time. And many countries actually supported this movement. And surprisingly, many scientists and doctors around the world also saw it as a scientific solution to social problem, which was very disappointing. And German and the Nazis in 1920 actually barred people from who have hereditary disease or epilepsy from having children. Forced sterilization and killing of children under the age of 3 were initiated. And also, all disabled people up to the age of 17 were killed. These are children and teenagers because they are disabled, they were killed. Altogether, about 60,000 persons with epilepsy were sterilized up to 1964. In Norway, until 1969, everybody was obligated to disclose his or her epilepsy before marriage. And if such information was withheld, the marriage could be annulled. The same thing with the US Immigration Act and Australia. And Australia actually barred people with epilepsy from migrating to their country until 1989. To me, 1989 wasn't so long ago. So we have discussed today about the impact of stigma in epilepsy and society, from labeling what the disease is, the misconceptions of the disease leading to discrimination, isolation, and then some of them wouldn't seek treatment, so treatment delay causing poor outcome and disability. We have learned today, I hope you have learned today, that epilepsy is a highly stigmatized disease. It is not contagious. Epilepsy, not all causes of epilepsy are hereditary. Epilepsy is not caused by demon or evil spirits. It's not a mental illness. Majority of people have normal IQ. Majority can have their seizures controlled and have normal life. And epilepsy patients can get married, get pregnant, and have children just like you and me. So how do we break this stigma? How do we do this? Why are you here today? Because you are the educators, counselors, and policymakers, the important pillars that can kickstart this effort, starting from your school. The parents trusted you, the children trusted you. They trust you as their support system when they're at school. They don't want to be discriminated. They want to be safe. They want to feel comfortable, confident, and most importantly, accepted for who they are and whatever disease they may have. So what are the barriers for children and adolescents? Some of them has been spoken to about by my previous colleagues, but these are some of the issues living with the disease. Remember, most patients with epilepsy have their seizure very well controlled, normal IQ, they don't have any problem. But living with the disease, some of them with frequent seizures may not even be accepted in certain school. They may have multiple sick leaves, missing out on class activities, and difficult to catch up with the syllabus. They may have drug side effects. They may be labeled as lazy or slow learner, but actually these are all to do with the side effects of the drugs they're taking. And they may be thought to be daydreaming in the class, but perhaps they were actually having very small, subtle absence or loss awareness seizures that may be missed. And embarrassment and fear of having their attacks in front of their peers. What will their colleagues think when they have an attack? And also the physical stigma and the restrictions put upon them. This may cause mental and physical disability. They were told not to do certain activities without supervision. They cannot join certain sport activities. What do we do? How do we actually include them in the group, and rather than shoving them aside and making them feel isolated? And all the school trips that they may miss, why will that be the case? Can they join these school trips? Is there a way we can make them participate in those school trips? And remember, don't miss that epilepsy children may have emotional disturbance, worry, stress, anxiety, and also depression. And of course, all the stigma restrictions we put on them may cause them to have loss of their independence and self-empowerment. They may be overprotected by parents or teachers because we don't know enough about their disease. Their educational and curricular potentials were limited and not fully explored due to poor understanding of their disease. They may be considered as physical and mentally disabled when they're actually not. And they don't want the sympathy from you. They want you to look beyond their disease and nurture their potentials. They don't want you to sympathize them. So what are the teacher's responsibilities? Know your student with epilepsy. This is why you're here today. You want to know about the stigma and explore the psychological issues associated with them. You have learned from my colleagues today about epilepsy, what epilepsy is in general, the type of epilepsy that your children have, what does it look like, is it well controlled, and of course, learning about proper first aid procedures if the children have attacks in school. and also learning about side effect of medications. Don't forget, depression is a big part of that may be missed in people with epilepsy. People with epilepsy suffers more commonly depression, anxiety, ADHD, but I'm not going to talk much about this. This will be spoken to by my colleague tomorrow. So what I'm trying to say today is that look beyond their disease. Now, this is Neil Young. He's a famous singer and songwriter. This is Edgar Allan Poe. He's a famous writer and poet. This is Teddy Roosevelt. He's one of the earliest American presidents. This is Charles Dickens. He has written endless amounts of children book. Even my children read their books, read his book. You know, if you remember Christmas Carol, Oliver Twist. This is Lewis Carroll, the famous writer of Alice in Wonderland. This is Florence Griffith. She is the fastest woman, one of the fastest women on earth. These are the people who have epilepsy, but look at their potentials. If you try to look beyond what the limitations, but explore the potentials and skill that these people have, you will see that people with epilepsy will surprise you. And there are organizations in this world that work together to promote access to care and protect the rights of people with epilepsy. We have Persatuan Epilepsy Malaysia here who fight for the rights and fight for the rights of people with epilepsy and try to spread awareness. What we want to say is that these children do not have to walk alone. School is an important support system that will make the child feel belong and not discriminated. It is a place where the children can show their potentials, and it is our role to make their childhood and journey of growing up a precious and memorable one. With that, I'm going to end my slide with this last saying. The history of epilepsy can be summarized as both superstition and stigma. Thank you.